We're going to cover the orbital disorders lecture this afternoon. I'll get through all of that in the 2 hours that we have, and then I'll just run through the red eye PowerPoint as well. Not really for any sort of testing purposes, but more just so you understand what that is. It's actually a pretty useful presentation. It's very short, so you guys can just print that out and have it in your office. And a lot of times it'll kind of walk you through step by step. If the eye is red, this is what you can do, and so on. So we'll do that today. Tomorrow, I'm not really going to come with much in terms of PowerPoint. Again, there's like a midpoint review slide that has 200 slides on it, and an end slide review with another like 200 slides on it. I'm not going to go through that tomorrow. Instead, I'm just going to bring Japan's blueprint for the eyes. I'm going to run through all the disorders. I have each test question associated with several of those topics, and we'll basically review what's going to be on the test. So, again, I've done that for like the last 2 classes, and it seemed to have worked pretty well. I'm not teaching you the test, but again, I'm basically teaching you the test. So. All right, any questions before we get started? Okay. All right, here is the blueprint for today. Talk about some corneal disorders, orbital disorders, trauma, and then a few neoplasms in there as well. Copious amount of topics on here. Okay. The first thing I want to talk about is triage. It's going to be pretty important to understand what diseases do I need to treat emergently, urgently, or what diseases can wait. Okay. So I've broken down several of the main visual concerning conditions that we've talked about. CRAO, chemical burn, orbital compartment syndrome we kind of went over, and then angle closure glaucoma. Okay. So these are true ocular emergencies, these 4 conditions here. What does that mean? These patients that have any of these conditions listed need to be treated immediately, right away, ASAP. Okay? A lot of times, if a patient has one of these conditions, we don't really do any sort of workup with the patient. We don't really take visual acuities. We basically just start the treatment right away. Okay? So I'm thinking a patient comes into your clinic or calls you over the phone and they say, I woke up, I can't see anything out of my right eye. Yeah, that should send several red flags off, right? And it's constant. They haven't regained that vision. You can't do anything really with that patient. You should just send that patient to the emergency room because they hopefully need to get on some sort of vasodilators to get rid of that block. A central retinal artery occlusion is the worst case scenario in a sudden painless loss of vision. You got to get that patient referred out. Chemical burn, you have to start irrigating that eye right away. So you got to get that Morgan lens or whatever irrigation that you have available to you. You got to start irrigating that eye immediately. Or it could scar and then be visually debilitating for that patient for the rest of their life. Orbital compartment syndrome, again, that is where there's bleeding behind the eye. And that bleeding is going to cause the eye to bulge forward. There's going to be swelling of the lids. You have to perform that lateral canthotomy canthelysis. We'll talk a little bit more about that here in just a sec. But that's going to be something that you have to do right away. And then angle closure, same thing. You got to break that angle closure attack. You got to get that angle open back up so that the aqueous humor can drain through the angle to lower that IRP. Okay. So these 4 conditions must be treated right away. Definitely know triage. Know what's in each category. Know what's in the emergencies, the urgencies, and then not so urgent conditions, because I will be asking you those questions. All right. Moving on to urgent conditions. Now, typically with urgent conditions, these still are very important to be seen and taken taken care of, just not quite as important as the 4 emergencies that we talked about on the previous slide. Okay, so these patients should be seen like as soon as possible, basically on the same day that they're calling you, okay? But these are things that you can potentially manage in your clinic or in optometry if it's right next door, or ophthalmology if they have availability. So we're thinking a severe hyphema. We haven't really talked about hyphema, we've kind of briefly covered it, but hyphema is blood in the anterior chamber. So if you get trauma to the eye, sometimes the iris and the vasculation inside of the eye can start bleeding, and you can get blood pooling in the anterior chamber. And we call that a hyphema. The severe hyphema we term as an 8-ball hyphema, because when blood completely fills the anterior chamber, the eye is completely black. Okay? There's no color at all to the eye. It's just pure black. Black like an 8-ball. That's why they call it an 8-ball hyphema. Okay? Not a drug reference. Black like an 8-ball in pool. Okay? So severe hyphema, severe periocular lacerations. So we're thinking like lid lacerations involving the lacrimal system, so more nasal lid lacerations. Those are going to be urgent conditions. Orbital fracture with muscle entrapment. So we're thinking if you get, again, trauma to the face, usually this is like a young 20-year-old male who went to the bar, had too much to drink, and then talked some smack and got hit. It's pretty common. They can get an orbital floor fracture, so the orbital floor bones can break, and the inferior rectus rests right on that orbital floor, and the inferior rectus can actually become trapped within the bone break there, and that's what we mean by muscle entrapment. So if you have somebody that comes into your clinic that's been punched in the face, they're going to know, hopefully they'll know, that they got punched in the face. And they're going to have double vision, specifically when they're looking up, because the inferior rectus is trapped and it's not able to move up. So if they get punched in this eye and they look up, this one's going to go up, this one's just going to be staying the same. So they'll double vision diplopia in up gaze because the inferior rectus is trapped. Any traumatic optic neuropathy, again, trauma to the optic nerve head, so some sort of blast or some sort of direct trauma to the face can sometimes either dislodge completely the optic nerve head or cause severe inflammation on the optic nerve head, which results in vision loss. Okay, those patients need to be seen urgently. And then corneal foreign bodies are something that needs to be seen urgently as well. These patients are going to be in extreme amounts of pain. You think, like, even if you get an eyelash in your eye, how frustrating that is, and how it's not really painful, it's just super irritating. But if you get an abrasion on the eye from a corneal foreign body, that's extremely painful, and you have to get that foreign body out. Okay. You guys, if you're the only medical provider around, I'm thinking like in a deployed location, and you're it as far as the eyes go, number one, good luck. But number two, if you have like a corneal foreign body coming in, you're 100% within your wheelhouse to get that out. If it's just a surface injury that's sitting on the cornea, just numb that eye up with Percaraine or whatever drops you have to numb the eye, and then you can take like a wet cotton tip applicator and just scoop it off. Okay? If you have a Woods lamp with some magnification, that's usually beneficial. Okay? So you can stain the eye with fluorescein and then really see where that lesion is, or the corneal foreign body, and just kind of scoop it right out. As long as the eye's numb, it's not going to really cause that much damage. And the eye is quite resilient, actually, so you can put a lot of pressure on the eye, scooping stuff out, and not cause very much damage at all. So don't be afraid of the eyeball. Well, everybody is, and that's why I have job security. But you don't have to be. It's quite resilient, okay? And then it heals itself 9 times out of 10. So those are the urgent conditions, and then we've got non-urgent conditions. So it's like an abrasion without any foreign body. Okay, other types of periocular lacerations. So if you get a lid lac on the superior lid or something up here by the brow, that's not super urgent. You guys are well within your wheelhouse to throw some sutures in there. Most other hyphemas, so we're thinking non-aqual. So if you can see any part of the iris behind, any part of the colored part of the eye, then that's not an aqual hyphema. Other orbital fractures, so again, trauma, but there's no muscle entrapment. The inferior rectus is entrapped, okay, that's not urgent. And then most retinal detachments actually are not urgent things that have to be taken care of. It's a little more of an urgency if the macula is still attached. So if you have a patient that gives you all of the signs and symptoms of a retinal detachment, flashes, floaters, a curtain falling over the vision, or any loss of the peripheral vision, it's probably a retinal detachment. But if you take their visual acuities and they're still reading 20/20, like the macula is still attached at that point. That's going to be more urgent, actually, than if they've got 2400 vision in that eye, because then we know the mac's off, and there's not a lot to do at that point. Like the retina's not going to go anywhere; it's still going to be inside the eye. And then ophthalmology will treat it. But it's not as much of an urgency as if the mac's on. So, does that make sense? Okay. All right. So know what's in those categories, again, because I'm going to ask you. Now we're moving on to preseptal and orbital cellulitis. So in the eyelid itself, let's do a little anatomy review. There is an orbital septum, and it basically is right here. Okay, that little piece of tissue, that is what guards basically the brain. If you get in front of the orbital septum an infection, not that big of a deal, because we can treat it and it's going to stay localized to the front of the eye. But as soon as you get behind that orbital septum, now any sort of bacteria has free range to the brain, and we don't want that because you can die. Okay, so preseptal cellulitis is some infection that happens in front of the orbital septum, anterior to the orbital septum. It stays localized in the eyelid. Okay. A lot of times you'll get preseptal cellulitis from a hordeolum. So a hordeolum, remember hordeolum hurts, that's that infection in the eyelid. Okay, if we don't treat that hordeolum right away, that infection can grow and involve the entire eyelid. So instead of just a little bump on the eyelid, a painful bump, hordeolum, you get the whole eyelid that is swollen with some sort of bacterial infection. A lot of times even the eyelid will be swelled completely shut. The patient can't open that eye. Okay. That needs to be treated, because if you don't treat preseptal cellulitis, sometimes that bacteria can burrow through the orbital septum and then get into the orbit and into the brain. Okay, so we got to treat preseptal cellulitis right away. And again, that's why I'm really aggressive with hordeolums, because I don't want them to turn into preseptal cellulitis. I had a patient who was out at Camp Bullis. She was an AIT student and was doing her FTX. It's field training exercise for the Air Force. They were sleeping on the ground. Okay, I know, it's crazy. Sleeping on the ground. She said she got a bug bite. Thought she got a bug bite, which is possible because those stinking ants out there are awful. Said she got a bug bite. Her lid started to swell. Her cadre took her to VAMC. VAMC put her on Benadryl. That was at like 2 in the morning, and then the TMC opens at 6, so it wasn't getting any better with the Benadryl. I saw her at 6, her eye was completely swollen shut. So in a matter of hours, her eye was completely swollen shut. And I was like, well, it's not an allergic reaction. It looks like preseptal cellulitis to me. Benadryl is not the wrong answer there, right? Because it potentially could have been an allergic reaction, but it also wasn't the right answer. I put her on Augmentin, saw her the next day. She was able to open the eye a little bit, it was still fairly swollen, and then saw her 4 days later and it was completely back to normal. wrote a nice little case report on that. But that was an interesting case. So bug bites can also cause preseptal cellulitis. It's not just a hordeolum. Sometimes if you get like a herpes lesion, either on the cornea or on the lid, you can get bacteria burrowing in that lesion as well. So anytime you have some sort of opening of the skin, you can get preseptal cellulitis. So the patient's going to have tender swollen eyelids, probably swollen shut, maybe a slight fever, but not much, because again, that infection is staying fairly localized to the eyelid itself, so it's not going to be completely systemic. The 4 things they have underlined here are very important to note, and these are the differentiators between preseptal, which is not that bad, and orbital cellulitis, which is very bad. With preseptal cellulitis, you will have no proptosis, so the eyeballs are not going to be protruding at all. Okay? You're not going to have any restriction on your ocular motility, so the EOMs will be moving wherever you want them to move, and there's also going to be no pain when you're moving your eyes. No pain with the EOM movements, and also no optic neuropathy. What does that mean? There's not going to be any apparent pupillary defect. No APD noted. No decrease in vision, no APD. Okay? All 4 of those things mean that the patient has preseptal cellulitis and not orbital cellulitis. Okay? Very important differentiators there. Okay, this is a picture of a guy with preseptal cellulitis. How do we know this is preseptal cellulitis? Again, it's on the preseptal cellulitis slide, so you know. But you can see this is kind of staying right around the eyelid. This lid is definitely swollen, but it's not going beyond this sort of upper eyelid area here. Okay, all that swelling is staying fairly localized to the upper eyelid. Same with this guy. This looks terrible, right? Absolutely terrible. Here's a picture from below. So a little bit of the eye is able to open, but not a lot. Okay? So when you're doing, when you're trying to see if a patient has proptosis or check their vision or their EOMs really, it's difficult to do when the eye is like this, because you can't see that eye. Okay? So you kind of have to do your best. You may need to move the patient to a position where you can see a little bit of the eye, and then you can kind of gauge whether the eye is bulging out at all or whether they can still move their eyes. Okay? No restriction on eye movements. You can do a pretty decent EOM evaluation with just that little bit of an eye if you're looking real close. Okay? So we give this patient oral antibiotics, Augmentin, Keflex, something pretty strong, and then we see him back and he looks back to normal. Okay? That is the goal. All right. So when you have a patient, you got to do that workup. Again, it's going to be a little bit cumbersome, especially if the eye is swollen shut. Ask him if there's any trauma. Okay, so for my patient that had the bug bite, I asked her if anything happened. She said she got a bug bite. She thought. And then Augmentin, Keflex, oral antibiotics. If the patient is, so we differentiate mild and severe cellulitis. Most preseptal cellulitis, if they have no proptosis, no restriction on EOMs, no pain on eye movements, and vision is normal, it's going to be mild. Okay? If any of those other boxes are checked, it's not mild anymore, and we're thinking orbital cellulitis, and then we pump to the ER, where they start IV antibiotics. Okay. All right, and that would be orbital cellulitis. So we've got, with orbital cellulitis now, that infection is broken through the septum, it's into the orbit itself, has free range to the brain. You've got pain on eye movements, you're going to have a proptosis likely with orbital cellulitis, a restriction of eye movements, and you're probably going to have an APD with this as well. Okay. So hordeolum can turn into preseptal cellulitis, which can turn into orbital cellulitis if you don't treat them right away. And this one's bad. You don't want this. Okay, so these patients are going to be in more pain, double vision, Warm, tender lids, they'll probably have a bit of a fever as well. Okay, proptosis, restriction on eye movements, and pain with the eye movements, potentially also that APD. Okay, this is a picture of orbital cellulitis. Again, we can tell that it's orbital cellulitis because it's on the orbital cellulitis slide. But the other picture sort of stayed, the swelling was kind of here on the lid. This swelling goes all the way above the eyelid there. Okay? So that's beyond the orbital septum. That's more of the orbital cellulitis. Okay, another picture. It's got some swelling. You can see kind of on that forehead area there as well. That's beyond the orbital septum. So this patient would have restricted eye movements, decrease in vision, pain on eye movements, and probably an APD as well. Okay, so you're going to do the same kind of workup as you do for preseptal cellulitis, right? And this is what a picture of kind of that proptosis. Okay, so you can see this eye is sticking out a lot further than this eye is. Some infection in there. That's not normal. Shouldn't be sticking out that much. Proptosis. And then these patients with orbital cellulitis require IV antibiotics. They have to be admitted to the hospital, and they need to get started on broad spectrum IV antibiotics. All right. Any questions on preseptal versus orbital cellulitis? Remember those 4 key things, and you'll be just fine. Okay, we'll talk about some tumors. Already kind of talked about basal and squamous cell carcinoma when we were talking about the eyelid. Now we're going to talk about some retinal tumors. So you can have melanoma. That is not a good cancer to get anywhere. But you can get retinal melanomas, choroidal melanomas. And the only way that we figure out that you have a choroidal melanoma is typically inadvertently when we're doing a dilated eye exam. So if you've never had a dilated eye exam, highly encourage you to schedule an eye exam and get your retinas checked. Even if you're 20/20, doesn't matter. You can still have a bunch of other things lurking around inside of your eye that we can manage when it's not cancer. Okay. Let's see. Astrocytoma is not super common, but it can present with that white pupil, the leukoporia. Anytime you see a leukoporia, that's not normal. You need to refer those patients out. Retinoblastoma is in kids. It's the most common intraocular cancer in children. And this also has that leukoporia. When Facebook was starting out and it wasn't as popular as it is now, I guess it's less popular now, but when Facebook was like Instagram popular, parents were posting pictures of their kids online, and there was a few instances of this where a parent would post a picture of their kid and the kid had a white pupil, and some eye care professional was like, you need to have your kid get an eye exam, and they had retinoblastoma. So Facebook's not all that terrible. So probably not great, but not terrible for that reason. Okay, this is a picture of leukoporia. You can see that patient's left eye is not normal. Okay, that is not a normal looking eye. Patient's right eye, not normal. There's something growing inside of there. That shouldn't be there. Okay. Another picture of a retinoblastoma. Okay, choroidal melanomas look pretty similar to this as well. It's just going to be a massive elevation in the retina, and those aren't good. So you can get mets from the choroidal melanoma down to your liver, and then you can die pretty quickly. So hopefully you don't get that. You should get an eye exam, though, so we can confirm that you don't have a choroidal melanoma. The way that they treat, and it's not on your slide, so I wouldn't worry about it if you don't want to worry about it for your test, but the way that they treat a retinoblastoma is, in a kid is typically by enucleating the eye, so they take the eye out of a kid, so that's kind of a traumatic experience for those kiddos. They're going to have some sort of prosthetic eye for the rest of their lives. Usually, prosthetics are they're pretty good in terms of patients with prosthetics if they're taking care of them, you can't really tell that they have a prosthetic eye. The people that create the prosthetics will take a mold of the orbit and then use clay to fine tune that mold, and then they'll make a porcelain insert for the patient's new eye, the glass eye, and then there's actually a painter that will paint the iris of the eye. So they'll take a picture of the other eye and then paint that iris on the eye, and they do just an absolutely incredible job. Patient puts the eye in, it's kind of like a contact. You want to think of it like that. They'll just put the glass eye in. It's not like a big round ball. Typically, with cases like this, the surgeons will try to leave enough tissue inside of the eye that there's a place to put a larger contact lens, basically. And then the patients will still have their extraocular muscles attached to that blob inside of the eye, so they can look around and move their eyes together. So it's not just staying in one spot, it actually moves around pretty nicely. Those patients have to take that glass eye out periodically and kind of clean it and then wash out that orbit, but it works pretty well, and the patients are really appreciative of it. Yeah?
You said children or adults.
What do you mean?
Would they do the same thing in adults, or is it different?
Yeah,
Okay.
yeah, they'll do the same thing, and you'll see probably some patients that have prosthetic eyes. It's one of the wartime injuries that you can get, and we're seeing a lot more head and neck injuries in the large-scale combat operations, especially with drones. Getting a lot more head injuries, a lot more prosthetic eyes. We make, the DoD has a site at Walter Reed where they actually do the prosthetic eyes, so the patients will get shipped up to Walter Reed, and the painter will be in there painting method guy. It's pretty cool. Okay, corneal abrasions. We talked about this already. These are very, very painful. This is a scratch to the eye. Okay, patients are going to be in a lot of pain. They'll be very light sensitive. That's what photophobia means. They'll typically have a foreign body sensation. You don't necessarily have to have a foreign body in the eye with a corneal abrasion, but anytime that epithelium is disrupted, it's going to feel like something's in your eye when you're blinking. Okay? That's what that foreign body sensation is. Obviously tearing, and then they're just going to be walking around with their lid closed. Okay? It's hard to get visual acuities on a patient with a corneal foreign body or a corneal abrasion because they're walking around with their lid closed. So if you have any sort of ocular anesthetic, repair cane, tetracaine, anything that you can get to numb that eye so you can actually do an eye exam, that's much more beneficial. You can't let the patient take the repair cane. So if you have repair cane in your office, lock it up, because the patients will try to take it because it feels really good that their pain is immediately relieved. But it only lasts for like 20-30 minutes, and then their eye's going to be in a lot of pain again after that, so they're going to want to swipe it. We can't have patients swipe it because they're at a little bit of a risk to melt their corneas off if they use too much repair cane. So don't let your patients take your repair cane if you have it. Okay, signs are going to be pretty obvious with the corneal abrasion, especially when you instill the fluorescein dye. Okay, that abrasion is going to glow when you put your woods lamp, or if you have a slit lamp and you're using that cobalt blue filter, that abrasion is going to glow. You'll see immediately that you have it. Okay, and then they'll also have immediate relief with that anesthetic. Okay? So if a patient's coming in with a painful eye, you put proparacaine in and they feel a lot better, it's on the cornea. You know it's a corneal abrasion. Okay, this is a large corneal abrasion. Not under blue light, but sodium fluorescein has been instilled here, and you can just see this is a massive abrasion, so you don't even really need a woods lamp to see that's a huge abrasion there. This is what it would look like underneath the blue light, though. It just glows. Okay. So what do we do for these patients? After we've confirmed that they have a corneal abrasion, we'll do a full slit lamp exam to see how big it is, and then we will evert that upper eyelid. A lot of times you can get a foreign body trapped underneath the upper eyelid, and every time the patient blinks, they're giving themselves another abrasion. So if you ever see that, if you have fluorescein in a patient's eye and it looks like track marks up and down, that are glowing, that patient still has a foreign body underneath their upper eyelid. So you gotta flip that upper eyelid up and then swipe that foreign body away. That's really uncomfortable to have done. So a lot of times we'll numb those patients' eyes prior to everting the upper eyelid. We used to torture each other when we were in optometry school, everting each other's eyelids. One of my classmates in optometry school is from North Dakota. Any North Dakotans in here? Good people. He's like a farm dude from North Dakota, though, and not very delicate, and he would just rip my eyelashes and then evert my upper eyelid. It was very painful. I have super sensitive eyes. I'm a big baby when it comes to my eyeballs being touched, and he was not delicate. So try to be delicate when you're flipping an eyelid. Okay, how do we treat corneal abrasions? You're always going to start with some sort of topical antibiotic, regardless of whether it was from a bacterial infection or if they got scratched with a tree. Remember we were talking about fungal keratitis? You're starting with a topical antibiotic there, regardless. Hopefully it starts getting better after 24 hours. Okay? If it does, then you just continue course. If it's getting worse or if it's not improving, then it's not a bacterial condition. That's when you would culture and consider fungal infections. But always start with the topical antibiotic. Okay. All right, this is showing you how to evert an upper eyelid. Okay. Again, you can kind of see pulling the eyelashes. It hurts. Got to get it done. Okay, patients who wears contacts in here? All right, you take your contacts out every night, I'm assuming? That's good. Good. Don't sleep in your lenses, okay? It's not the end of the world if you do. 99 out of 100 times would be just fine, but that one time can be bad. So you can get a bacterial infection there and then give yourself an ulcer. Not a good thing to do. Don't sleep in them. If you have a patient that's sleeping in contacts, they may still have or has had some sort of contact lens issue. They may still be wearing their contacts. I had a patient did a Manning assist at Fort Carson, and they were doing some field training out there. It's like a young private. He came into the clinic in a wheelchair, bro. I think he could probably walk, but he's in a lot of pain, obviously. Couldn't open his eye. Said he got something in his eye in the field, and he was wearing his contacts. So I said, "Why are you wearing your contacts out in the field? You shouldn't be." And then I looked at his eye and I was like, "Dude, you still have your contacts in. Like, probably should have taken that out. You gotta take your contacts out right away. If you get something in your eye, take your contact out first. That's the best thing you can do. Don't continue to wear it." He did. I removed it and then treated him. He was having some irritation. Anytime you have irritation on the front surface of the eye, you're going to have redness to the eye and probably some tearing. That's pretty common. Okay? Contact lenses can obviously cause this because you're putting some foreign substance onto the eye. Again, most of the time you won't have any irritation with contacts, but that one time that you do, you're going to feel it. This is a picture of a patient who's wearing a hard contact lens, rigid gas permeable lens. Okay, these are not soft. They are hard pieces of plastic that sit right on the patient's cornea. Patients that wear RGPs love them because their vision is very good out of them. Patients that have never worn RGPs don't like to start wearing them because they are very painful. It's like having a rock in your eye all the time. You have constant foreign body sensation, especially if it's poorly fitting. This is a picture of that same lens after sodium fluorescein has been instilled, and you can see the fluorescein is pooling underneath the edges of the contact here, so it's kind of floating over the cornea, except for right here, where that contact lens is rubbing right on the patient's cornea, causing a corneal abrasion that you can see right here. That's a large corneal abrasion from that contact lens. So we want to have a properly fitted contact lens. Just have that patient go to optometry to get the contact lens refit. Okay, we talked about Pseudomonas already. That's a bacterial infection you can get from wearing contacts. That is not normal. Okay? You can see the eye is red, but you don't even need a slit lamp to see that there's something growing on that eyeball there. It's Pseudomonas. You can also see there's a little hypopyon in the bottom here on this picture. So there's an anterior chamber reaction too. There's white blood cells floating around in the anterior chamber, also not normal. Okay, another pseudomonal ulcer here. This is from a contact lens wearer. I can't believe you went swimming in your contacts. Acanthamoeba right here, that ring ulcer. That again is something you don't really need a slit lamp to see. The patient's eye is going to look real funky. Okay. Very difficult to treat though, so don't swim in your contacts. And you get GPC. This is my boy Jordan Groff took this picture. You can get giant papillary conjunctivitis. This will happen when you wear your contacts too much and protein builds up on the contact lens itself, and that protein will start rubbing on the upper eyelid, and then you get these giant bumps. You can see, it's not a great picture. The upper eyelid has a ton of bumps on there and they're huge. It should be nice and smooth on that palpebral conj. Those bumps act like little suction cups. You can think of like a octopus tentacle with those little suction cups. And every time that patient blinks, those suction cups are going to adhere to the contact lens and pull the contact up and down. That's going to cause irritation as well. How do we treat this? Take your contacts out. Okay. And then that protein buildup will go back down. Okay, so anytime you have a patient coming in with a history of contact lens wear and their eyes are irritated, you got to do a full eye exam, full slit lamp exam. If you have a slit lamp, great. If you don't, punt it to optometry, okay, where we'll do the full slit lamp exam. If you have the stain them, and you'll probably see that there's some sort of defect there. You can evert that upper eyelid too, make sure everything's fine under there. The treatment for contact lens irritation is pretty self-explanatory. Step one, remove the contact lens and wear your glasses. Okay? That's why you should have 2 backup pairs of glasses if you wear contact lenses. Okay, so if there's no other abrasion, then we just keep them out of contacts for 2 weeks and then baby step them back into wearing contacts. If there is an abrasion, then obviously we treat it with topical antibiotics. Okay, you can get ultraviolet keratitis. This is from some sort of ultraviolet radiation on the eye. We see this a lot after solar eclipses. Patients will get ultraviolet keratitis. They'll also get retinopathy with solar eclipses, because even though the sun is eclipsed by the moon, it's still not fully eclipsed typically. Patients just stare at the sun. That's a bad thing to do. Your eyes are not super tolerant to that. You can also get ultraviolet keratitis if you're a welder. Any welders in here? No welders. If you ever take up welding, make sure you wear your welding mask, okay? Because that arc that the welder gives off is very bright. You need to wear a proper welding mask to protect your eyes. Patients can also get ultraviolet keratitis if they're skiing or snowboarding. It's very bright. If you've never done that, very, very bright. So make sure you're wearing some sort of sunglasses or goggles to protect your eyes. If you don't, typically just like any sunburn, it's not going to onset right away. It like takes a few hours before your cornea is like, ow, that hurt. And you'll see staining on these patients. They'll usually tell you what happened though. Pretty easy to tell what's wrong with the eye. I was looking at the eclipse and I wasn't wearing protection, or I was skiing, or I was welding and I didn't wear my eye protection. So they'll know something's wrong, and then you'll see signs on the cornea. The cornea is going to be not looking nice, so you'll stain it and it's going to be glowing with the stain. This is a picture of what ultraviolet keratitis looks like. So if you stain that, that's going to glow. All of that stuff in there is going to be, those epithelial defects will all glow with the stain. Okay, another picture under the slit lamp of ultraviolet keratitis. How do we treat these patients? We're worried about anterior chamber reactions with these patients, so we'll treat them kind of like uveitic patients, where we dilate the eye to prevent any sort of anterior chamber reaction. And we'll also use an ointment here not typically for the antibiotic properties, but more because the ointment stays on the eye and it protects the eye and it makes it feel a little bit more comfortable. Then you can just do pain management with oral Tylenol, ibuprofen. All right, let's take 10 and then we'll jump back in. The next condition we're going to talk about is any chemical injury. We've already hit on this quite a bit. This is a true ocular emergency. Anytime a patient gets something into their eye, whether it's an acid or a base, that's a bad thing. You need to start irrigating that eye right away. Okay? Of note on this slide, base burns are actually worse than acidic burns. The basic burns, the alkali burns, actually eat their way through the cornea, which is not a good thing. Acid burns just tend to scar really bad, but kind of sit right on that top layer and don't burrow their way through. Patients are going to have some pretty severe symptoms typically if they get something into their eye. A lot of pain, redness, and an obvious history of chemical exposure. These are usually pretty easy to diagnose because the patient is already diagnosed it. Okay, if you're concerned about signs, if you don't believe a patient, you may see some corneal epithelial loss, some staining. Chemosis, again, is swelling of the conjunctiva. Redness on the conj, you may have a subconj heme. Okay. And the worse that these burns are, the more pronounced the opacification of the cornea is going to be. This is bad. Right? It's from a chemical injury that didn't get treated soon enough. And you can see there's already vascularization encroaching its way over the cornea there. That's a bad eye. More chemical burns, chemical injuries. So the eye has been burned so bad that the body's like, yeah, you're not going to be an eyeball anymore. We're just going to throw some opaque tissue over that to try and heal the wound. That's why it's really important to start irrigating these patients right away. We want to prevent stuff like this from happening. It's an unhappy eye. Can't even see anything beyond the front of that eye, so the patient can't see anything either. Okay, that's a pretty active chemical injury right here. Okay, so we need to get this irrigated. The eye is bright red, and there is a lot of white blood cells, a lot of white blood cells floating around. In the anterior chamber there, that is all, that whiteness is all hypopyon, white blood cells in there. Okay, that doesn't even look real, but it is. That's what happens if you don't irrigate right away. So make sure you irrigate right away. And again, you don't need a Morgan lens to irrigate an eye. If you have it, it's probably the easiest way to do it. But if you don't, start dumping that eye with water. Okay? It doesn't have to be sterile water. It doesn't even need to be clean water, really. Any water with a pH of 7 is going to neutralize an eye. So if all you have is dirty pond water, okay, I would still use that over not irrigating that eye. I can treat the bacterial infection that's going to occur after that, but at least that cornea is not going to scar. Okay, so start treatment before you evaluate this patient. When they call or they come into your clinic saying, I got something in my eye, some substance, start irrigating right away. Okay, then check the pH. After that, you can do the rest of your eye exam after you irrigate that eye and have gotten that pH back to normal. Also, don't irrigate a base with an acid. That will just cause scarring right away. Only use something with a pH of 7. Okay, corneal foreign bodies. Again, uncomfortable. I got something in my eye, and it's still in my eye. Okay, sometimes they'll be able to see something in their eye. Sometimes they'll just feel like something's in their eye. So you got to do a full eye exam to actually see if there's anything still in the eye. Right? There's going to be redness, but obvious pain, and typically the patients will say, "There's something in my eye." Here's a picture of something in an eye. Again, that shouldn't be there. Okay? So this is metal. This is a metal fleck or metal piece, either from grinding or working on a car or something, some piece of metal fell in this patient's eye. When we remove that, they'll have what's called a rust ring. Not ideal, but also not a terrible thing. A lot of times this rust ring, as the corneal layers regenerate, it'll just push that rust right out. So we don't really worry too much about a rust ring. Just get the metallic piece out. Okay, if a corneal foreign body is coming at a higher speed, sometimes it can puncture through, and now it's not a corneal foreign body anymore, now it's an intraocular foreign body, but it can cut through the cornea. That's a bad thing. Okay. This next picture, there's a foreign body in the palpebral conge here. So we've everted that upper eyelid, and you can see that speck right there. Technically, that's a conge foreign body, but it's doing this tracking on the cornea every time the patient blinks. And it's leaving a corneal abrasion with that conjunctival foreign body. That's why we evert the upper eyelids to do that sweep, and then you just take a CTA, wet CTA, and swipe that piece off. And then it'll be back to normal. Another conge foreign body here. Okay, this is simple. Just take a cotton tipped applicator, numb the patient's eye, moisten the tip of the cotton tipped applicator. I'll usually just moisten it with a Barricane too, because it's additional anesthetic, and just sweep that right off. Very simple. Don't be afraid to do that. Okay, so the workup for these patients, mostly on the patient's case history. They're going to tell you that they got something in their eye. Check their IOPs, potentially. You'll just slit up exam. If you're concerned at all that the corneal foreign body is not in the cornea anymore and it's actually in the eye, do a CT scan. This is where definitely don't do an MRI. We're talking briefly about CT versus MRI. Don't do an MRI if there's an intraocular foreign body, for obvious reasons, right? If you don't see anything, if there is a globe penetration, you got to punt this right away to ophthalmology. That's the same thing I'm going to do, because I can't do anything about it. Punt it to ophthalmology, and they will get the foreign body out of the eye. So you'll just put a Fox shield on, basically. Ship and, or shield and ship is what ophthalmologists say. Just shield and ship it. Okay. Say that 10 times fast. You can put anesthetic on there, try to make the patient as comfortable as possible, but basically just protect the eye and then punt them. Okay, love this clip art here. This guy's doing some metal work. Okay, this is what they did back in the day. On an anvil there, and you'll notice they are not wearing eye pro. These are bad patients here. Okay, you can get a metal chunk flying into your eye at high speeds, and then you'll have eye pain, decreased vision. Okay. Sometimes it's not a suggestive history. So some patients with intraocular foreign bodies will not know that they have an intraocular foreign body. They will not actually feel anything, because there's no, if it's such a high speed projectile, it's just gonna right through, and they're not gonna feel it. They may notice that there's like vision changes inside of the eye, or they may get a reaction, an inflammatory reaction inside of the eye, but they may not know that they have an intraocular foreign body. Although most of the time they will. So an intraocular foreign body is a bad thing. Okay, shouldn't have anything inside of the eye except the stuff that's supposed to be in there. They may have a detectable penetration site, and you will be able to see that typically by the patient having what's called a peaked pupil. So instead of a round pupil, it'll look like a teardrop. And the point of that teardrop is going to point to where the penetration site is. Okay. They may also have bleeding inside the eye, decrease in IOP. That should be pretty obvious why, right? The eye's leaking, so it's going to be less pressure inside of there. Decrease in vision. Okay. So here you can see the peaked pupil, right? That's not a round pupil anymore. And then here is something. What is this? It's not the foreign body. That is iris that is peeking out or trying to seal the wound. So because of the pressure gradient inside of the eye, if you get something that goes through your cornea into the eye, there's more pressure in the eye than there is outside of it. The iris is going to seep forward and essentially plug that wound, okay? And that is why the pupil is peaked, okay? Because the iris tissue has been pulled to plug that wound. So ophthalmology will go in and push that iris back in and then seal the cornea up. That is very indicative that there's an intraocular foreign body. Okay, here you can actually see an intraocular foreign body. Again, there's a peaked pupil there. Okay. Another peaked pupil here. Anytime you see this, suspect that a patient has an intraocular foreign body. You may be able to see it. You can see that there's something in that eye there. You're definitely going to be able to see this. Okay, that's an obvious intraocular foreign body. Okay. So you can get fish hooks inside of the eye. You can get, if you're using a wire wheel to polish some metal up, you can get one of those wires popping off into the eye if you're not wearing eye pro. This is bad. Not necessarily terrible though. So depending on how far this scar spreads, this guy might actually have a pretty good visual outcome because the visual axis is still relatively clear right there. As long as ophthalmology can get that thing out and it doesn't continue to scar, this patient may not have a poor visual prognosis. Okay, another picture, something in the eye there. Should you remove this? No, don't remove it. Okay, ophthalmology will remove it. Please don't remove it. What you should do instead, if you can get a Fox shield over it, put a Fox shield on it. If you can't get a Fox shield over it, put a cup or whatever. Okay, the cup provides no protection whatsoever, none. It's a freaking solo cup. The only thing we're doing with that cup is drawing attention to that patient's eye, saying there's something jacked up with this guy's eye, please don't touch it. Okay, that's all it's doing. It's not protecting it at all. Yeah.
So when they look around, is there a risk of it causing more damage? Or?
Potentially, but not really. So they'll tell you to patch the other eye, or patch both eyes, or cover both eyes. That used to be what we did, and then they're like, well, if we patch both of this patient's eyes, now the patient can't see, and they're not ambulatory anymore. It's better to be ambulatory. If one eye works, keep that eye working, patch the bad eye, protect it, and then that guy can hopefully, or gal can run to where they can get treatment. Okay, so as a general rule of thumb, just patch the bad eye. Put a Fox shield over it, or a cup if there's a huge thing sticking out. Okay. This is a pencil in the orbit. Okay. Would not recommend. But again, probably not that bad of a visual outcome for this patient because the eye doesn't really look like it's been penetrated all that much. The visual axis is probably fine, and the optic nerve looks like it's untouched as well. So not great. Looks like they've got some orbital bone fractures in there, but not a terrible place to get a pencil if you have to have it. Okay, we're going to do a workup on these patients. Obviously, again, you're looking for that peaked pupil if there is one, or a decrease in intraocular pressure. Never pressure patch a patient with an intraocular foreign body, because if you pressure patch, you're going to push more of the inside of the eye out, and we don't want to do that. Never pressure patch these eyes. And essentially, you're probably never going to pressure patch an eye ever. Okay? Just put a Fox shield on. No pressure on the eye. The only time you're really ever going to pressure patch is if you have like a lid laceration with no intraocular foreign body, no open glow. Then you can pressure patch that lid, but it'd probably just be better to put some either butterflies or suture it if you can right away, and then put gauze over it. Typically, we don't ever pressure patch. They still teach pressure patching. I don't know why, because you're really never going to pressure patch an eye. Just put a Fox shield on it. All right. Treatment for an intraocular foreign body. punting to ophthalmology. Punt, okay? They are gonna take care of it. I also, again, punt this. The retina docs or the emergency room ophthalmologists are gonna take care of that. They'll give IV antibiotics, probably, and then cycloplegics for pain after they get whatever is out. Okay, we talked about blow-up fractures already. If you get punched in the face, in the orbit, you can get a bone fracture, especially on that floor. And we're concerned with the floor specifically because you'll get that inferior rectus trapped, and that is going to be higher on the list of triage. They're going to have a history of significant blunt trauma, okay? And unless they were drinking so much that they don't remember what happened, their friends probably will, but they're going to know something's wrong. You're also going to know something's wrong because it's going to look like they got punched in the face. The lids are going to be swollen, there's going to be bruising around the lids, and then you're just doing your EOM checks. So we got to make sure that there's no retinal detachment, because you can get punched so hard that your retina detaches. So do a visual acuity check with these patients, do an extraocular muscle check with these patients, making sure that there's no restriction, no double vision, ask them if they have double vision. Okay. Then we're going to treat the blow-up fracture after that. So this is a picture of somebody with muscle entrapment. Both of these pictures, actually, my boy Jordan Groff, again, he is everywhere. So in the picture on the left, the patient's left eye is trapped. The picture on the right, the patient's right eye is trapped. The left eye does not look as severe, it's less obvious that there is a fracture there. The patient on the right, it's pretty obvious that eye got punched. Okay, another, you can see here that the eye on the right side of the picture, the left eye is kind of sunken in a little bit, and it's not sitting where the other eye is, it's displaced. Okay, that's indicative of a blow-up fracture as well. And then there can be a lot of swelling around the eye, as you might expect. Okay, there's a blow-up fracture here on the right medial wall. Okay, you can see that right here. That should be all intact like this eye is. It's not, it's broken. That is an orbital blow-up fracture. Okay, what do we do? Evaluate the EOMs, make sure there's no restriction, rule out a ruptured globe, rule out any retinal damage as well, do a CT scan on these patients, and then punt them to ophthalmology. Okay, you can give nasal decongestants anytime you have any orbital issues. A lot of times we'll give nasal decongestants because they're going to be real swollen inside of there. You can give prophylactic antibiotics as well, oral, just to prevent any sort of bacterial infection, because now you've got free access again to the brain from the sinuses that can cause an orbital cellulitis. Ice packs, obviously. Okay, here's hyphema, blood in the anterior chamber. We've seen this already, we've talked about it already. Anytime you can get trauma to the eye, you may be susceptible for a hyphema. This trauma can come from getting punched in the face, getting shrapnel, anything to the face. Cousin had a hyphema when we were growing up. We were paintballing in the woods in Wisconsin, and it was cold. His mask was fogging up. He took it up to wipe the fog off, and when he took it up, he got shot in the eye. Didn't damage his eye. He did have a hyphema, and then he also had an anisocoria afterwards because the pupil was a little bit larger than the other one. Overall, he's still doing just fine. If you have hyphema in a kid, you may want to figure out a way to ask a question about potential abuse. Okay, hyphema is not normal. It's indicative of some sort of trauma to the eye. Okay. Signs and symptoms. The most obvious sign is going to be blood in the anterior chamber, okay, that you're going to see. The pupil may be irregular in these patients as well. Okay. You can see that here. The blood is in the anterior chamber here, sinks down to the bottom. It's like that nice little bit of blood in there. and then you can see the pupil is kind of elongated or oval here, and that's just because the blood in the anterior chamber is not allowing that pupil to constrict as much. It's pulling it down. Okay, obvious hyphema here, pretty obvious hyphema here. None of these are 8-ball hyphemas. Okay, I don't have a picture of an 8-ball hyphema, but it's essentially, instead of just being blood right here, it's blood all the way up to here, and that eye is going to be completely blacked out like an 8-ball. Okay, histories for these patients, figure out what happened, when it happened. It's going to be due to some sort of trauma. Okay. Got to evaluate the patient's intraocular pressure. Why do you think that would be important? The anterior chamber angle is where the aqueous drains out, and if that angle is blocked via the blood, then they can have a spike in IOP. They can potentially have traumatic glaucoma. Okay. How do we treat hyphema? Just let the blood resorb. Okay, so these patients are typically on bed rest with the head slightly elevated. You want to keep that blood in one spot and let gravity do its thing. And eventually, like all other bleeds inside the body, that blood will be resorbed into the bloodstream and go away. Don't pressure patch these eyes. You can put a Fox shield over it, but never pressure patch. Okay. Lid lax we'll cover briefly here. A lid laceration is just what it says, a cut to the eyelid. Okay, there's going to be obvious signs for this, and the lid's going to be cut. And usually the patients will have a history to tell you as well. Okay, like this guy working with a crowbar, hit himself in the eye. That's, I don't know how that happens, but he wasn't wearing eye pro. Should have been. And he has a not only a lid laceration, but he's got an orbital fracture there as well. Our boy Jordan again. Lid laceration. Okay, that lid is clearly sliced right here. Okay. Those are tricky to patch up. A general rule of thumb for suturing an eyelid. Who feels like they could suture an eyelid in here? Yeah, all of you can. Okay. At the end of the day, all of you could suture an eyelid. Okay. If you can suture an arm, you can suture an eyelid. The beauty of what we have in our arsenal as far as eye care treatments go is called oculoplastic stocks. Okay? And every single oculoplastic surgeon that you see will tell you to treat it and patch it up as best as you possibly can. Get that patient stabilized as best you possibly can with whatever garbage suturing you want to do on there. Get that wound closed as best as possible and ship them back there, and they'll make them look beautiful again. Okay? The plastic stocks just want the eye saved, they want vision preserved, and they want a wound closed. They do not care. They will fix the rest of it. They're like absolutely the best Michelangelos. They're not Picassos. They are pristine in what they do. They can really recreate a patient's face. So just get this patched up. Throw a suture in there. If you don't feel comfortable with sutures, you can glue it potentially to close it up. Throw some butterflies on there. That's not going to hold very well. Sutures would probably be the best thing to do for this patient, just to get that wound closed. And then evaluate that eye for any sort of intraocular foreign body. And if you determine there's no intraocular foreign body, IOP is the same, it's not decreasing at all, then you could potentially pressure patch this eye. Yeah?
Would you recommend starting your suture on the border and then kind of quartering it, or just kind of going center?
However you feel comfortable. Like there's a ton of different ways to do it, and your suture is only temporary. Even if the wound starts healing back together, plastics is going to come in and cut whatever is healing anyway and resuture it. Just get it closed. Okay. A lot of times they'll teach you to start in the center and then kind of work your way out on lid lacerations like this. You want to try and get these lids positioned as best you can. Like you don't want this lid up here and this one down here. You'd want to try and position those lids a little bit. This portion of the lid is up because the contact applicator's pushing it up. So try and align them as best you can, and then just throw some sutures in there to close the wound up. That's all I gotta do. This one is much less concerning as well because it's not anywhere near the lacrimal system. So like the nasal injuries, like if this patient's injury was right here, nasally, that would be a little more concerning because you got like the canaliculi and the punctum and the nasolacrimal duct and all that stuff to worry about. Still, like if you can't get this patient evac'd out to ophthalmology within 24 hours and you're going to be holding them for a week because you don't have any air support, just throw a suture in there and close the wound up. Okay? Prevents infection and starts the healing process. Okay, this is more of a nasal lid laceration. Okay, and the book and the slides are going to say you guys probably shouldn't throw sutures in if the lacrimal system is involved. But again, operationally, if there's no eye care support, just close the wound up and plastics will figure it out. They're very good at it. More lid lax, more lid lax, more lid lax. Okay, suture. All right, working up these patients, full eye exam, you want to dilate the eyes, you want to make sure that there's no other injuries, no foreign bodies, anything like that. And then suture. Okay. If there's metal, you can do tetanus prophylaxis, oral antibiotics. If there's a suspected foreign body, it's never a bad thing to give a patient, especially operationally. Referral to ophthalmologist for repair if, number one, if they're available. Okay. If you're here stateside and they come into the TMC with a lid laceration, punt them right to ophthalmology. Okay, don't throw a suture in there. You'll probably get yelled at. But again, if you're by yourself on an island, if you're in, I don't know, New Mexico somewhere and there's no ophthalmologist for hundreds of miles, just throw a suture. Okay, close it up. Here is a brief overview of orbital compartment syndrome. Kind of talked about that already. This isn't one of your ocular emergencies. Okay, there's an increase in intraorbital pressure. It's not intraocular, but intraorbital pressure that can result in ischemia for the optic nerve. Basically, you're going to get a lot of times retrobulbar behind the eye bleeding, retrobulbar hemorrhage that's going to push the eye forward, and that stretches out the optic nerve. That is bad, because that's going to cause ischemia to the optic nerve and blindness. Okay. So again, how do you get it? This is typically due to some sort of trauma to the face. You're not just going to wake up and have orbital compartment syndrome. Some sort of traumatic event happened. You either got hit or some explosion happened and you have orbital compartment syndrome. So because the orbit itself is bone, it's not flexible. So there's no place for the inner contents and that pressure to go down. Okay? The venous return doesn't work as well when that compartment syndrome is occurring. So you're going to get proptosis, the optic nerve is going to stretch and become damaged. How do we treat orbital compartment syndrome? Lateral canthotomy, canthelysis. Okay? Lateral canthotomy, canthelysis. You have a patient with orbital compartment syndrome. Their lids are going to be swollen, their IOP is going to be through the roof, there's going to be some sort of trauma that just occurred to this patient. Okay? So it differs from like angle closure glaucoma. There's no trauma that happens with angle closure glaucoma. Some sort of trauma here has caused an elevated IOP, proptosis, huge lid swelling. That's orbital compartment syndrome. You have to do a lateral canthotomy, canthelysis. So you're going to, if you have anesthetic available, line it with epi, you'll numb that area up. You're going to make an incision on the lateral canthus. Okay? It can be with a blade or a scissors. And then there's two little tendons that hold the eye in place. You're going to snip the lower tendon there, and that's going to allow the eye and its contents to kind of come forward and allow that blood then, with the venous return, to escape the orbit. This video that I have here, it's a really good video going over lateral canthotomy, canthelysis. And it's not just eye people that do this. A lot of ER docs, if they have a patient with trauma to the face and there's even a suspected compartment syndrome, they're just going to do a lateral canthotomy canthalisis. And then going back to the plastics docs, they are very much in favor of just doing a lateral canthotomy canthalisis, even if there's no compartment syndrome, because they can fix it with no issues. They would much rather have you err on the side of doing the lateral canthotomy canthalisis than not. So ER docs are doing this, PAs downrange are definitely doing this. If you're confused or you don't know how to do it, like hop on a phone and hopefully you have either the brigade surgeon or some ophthalmologist that you have a contact with, okay, to walk you through it. But this is a really good video to watch, and this is a potentially a sight-saving procedure as well. If you don't get the compartment syndrome reduced within an hour, a patient's going to be blind forever because the nerve's going to die, the optic nerve, and that's a bad one to have die. Okay, so 100+ slides. Any questions on that? Don't be afraid of the eye. It's fairly resilient. You still probably will be, and that's okay. That's what we're here for. But it's pretty resilient. You guys can do a lot of treatment involving the eye, and the patients will be very thankful on the backside. All right, let's just run quickly through this red eye walkthrough. There's only 7 slides. And again, this is one that I would consider printing out and just putting in the office. Okay, this is all things highlighted here, but this is going to cover your common things that you're going to be seeing in the clinic that you're able to treat. So lid issues and red eye issues. All right. So with the lid, patient's coming in. They've got a bump on the lid. Okay. You're going to ask, is it painful or red? Yes, it is. What do you think? Probably a hordeoma. Yeah, very good. It's not. What are you thinking? Lazy. Very good. Okay, super simple. Just keep it that simple. Okay, no bump, but we've got crusty and red lid margins. Blepharitis, right? No crusty lid margins. No. Is it swollen and tender? Yes, it is. Do we have pain on eye movements? Yes, we do. We've got orbital cellulitis. No pain on eye movements, just preceptal cellulitis. Look at that. Super easy. Eye care is super easy. Okay? That's all you need. Good to go. So that's basically lid differentials. Patients come in with eyelid issues, and they will into the primary care clinics. This is kind of what you can use to run through and figure out your diagnoses. Okay, red eyes now. My eye's red. Does it look like blood? Yes, it does. Is it on the white part of your eye? Yes, it is. Well, that's just a subconjunctival hemorrhage. It's nothing to worry about. It's not on the white part. Is it over your iris? Yes, it is. Well, now you've got a hyphema. It's a little more worrisome, but still not that bad. Okay? Ooh, no it doesn't. We gotta go to the next slide. Is there any discharge? Yes, there is. What type is it? Mucopurulent. You've got bacterial conjunctivitis. Okay? It's like a ropey discharge. My eyes itch. You've got allergic conjunctivitis. Is it watery? You've got viral conjunctivitis. Oh wait, if you have a history of trauma, you have a corneal abrasion. No history of trauma, and they're dry and gritty. Now you've got dry eye. Not dry and gritty. Now you've had a recent URI, upper respiratory infection. Now you finally have viral conjunctivitis. Geez, myself there. Okay. Is there a white spot on your cornea? Now you've got some sort of corneal infection. Okay? No, there's no discharge, but is there pain? It's mild. Episcleritis. Deep, boring pain. With a dilated pupil? Ankylosing glaucoma. No dilated pupil, scleritis. Easy peasy. super simple. Eye care is not that big. It's pretty much a test, yeah. Basically, that's it. No, I have a little bit more on the test. But honestly, not too terribly much more. Okay, so if you're going through the test vignettes, just pick out those context clues, you'll be able to. I'll be walking around. Very much in favor of answering questions. I'm not going to give you the answers, but I'll answer your questions. Okay, so for tomorrow, again, I'm not even going to bring my laptop because I'm not going to go over any slides tomorrow. I'm just going to run through the PANCE blueprint and things that you should know. Okay. Not every single topic on the PANCE blueprint is on the test. However, it's on your PANCE blueprint, and I want you to pass your boards, so we'll talk about it. Okay. Some of the things that aren't on your blueprint that are on the test, we'll also talk about. So just take good notes tomorrow, and you'll be good to go. All right, we'll see you tomorrow afternoon.